Good morning, students. Can you identify what this is? Yes, it is uterus, cervix, and your fallopian tubes. Okay, so yes, so this part is called the cervix, and this is the lower uterine segment, and this is the isthmus. This is the cervix. This is the cervix. This is the lower uterine segment. This is your uterus. This is body of the uterus, and the part which is above the insertion of the fallopian tubes, it is called as the fundus. Yes, and then now when you cut it open coronally, in the coronal plane, this is how we find our uterus. Okay, so this is the cervix. Up to this part, it is the cervix. This is your cervical cavity, which opens into the endometrial cavity. So your endometrium is such a small portion, and a triangular one with almost just being a space. It is not a cavity as such in a normal uterus. So this is the myometrium, and this is a fresh specimen, an unfixed specimen. So this is your cervix, this cervical canal, the endometrial cavity, and the myometrium, and this part is your fundus, the cut open of your uterus. Now these are different sections taken when you cut open your uterus in the AP plane, anteroposteriorly. That was in the previous, this was in your it was cut open on both lateral sides, and when you cut it open in the AP anteroposterior direction, this is how you find it. Your uterine cavity is just a slit like space, and this is your myometrium. Okay, so your uterus, your uterine cavity looks like this. And this is the small, thin, shiny portion is your endometrium, this side and that side, and this is your myometrium. Do you find a difference between the previous sections? Yes, compare it with these sections. Are you finding a difference? Do you find how your uterine muscle and the endometrial cavity looks like here? This is just cut open after the excision of the specimen from the body. Now this is the section of the uterus which is already fixed. When we remove a portion of when we remove an organ or a portion of an organ from your body cavity, what happens? The blood supply is cut off, is it not? And once the blood supply is cut off, it is not having the nutrition, and the metabolism of it is not maintained. So the tissue gets degenerated. To keep the tissue intact and in as close as the living structure process to preserve that tissue in the near living state, what we do is we put the specimens in formalin, is it not? So when we put the specimen in the formalin, we call it as fixation of the specimen. Fixation of the specimen it is something like dehydrating your foodstuff for preservation. This is something like that. It is not the same. It is something like that. Okay. So this is done to preserve the degeneration of the tissue, and we can preserve such a specimen for a long time for the future use. Okay, so that is called fixation. and once the specimen is fixed, your organ looks like this. Yes, please compare it again. See, this is a fresh specimen, an unfixed fresh specimen which has been taken out from the body, and this is a specimen which has been fixed in the formalin. See, this portion is still yet not fixed. This is all a fixed portion. So this is your uterine cavity, and this is your myometrium. In this specimen, we are finding that the anterior portion is hypertrophied. Yes, this is again a specimen which has been removed from, which has been excised from the from a human, and then from a patient, and then it has been photographed immediately after it has been removed. Now what are you finding? This is again a uterus. See, this, the pear shaped structure is what is the one which is telling you that it is a specimen of the uterus. And then when you look at the endometrium, the endometrial cavity seems to be enlarged. Compare it with the normal which I have shown you in the beginning of this class. It seems to be enlarged, and we are finding outgrowths into the cavity which are called as polypoidal growth. Okay, and when you look at these polypoidal growth, it seems to be invading into the myometrium, and look at this, there are certain swellings even on the serosa. Yes, so this is a specimen of a malignancy, is it not? When it is well circumscribed and it is not pushing and invading into the other tissue, we call it as a benign tumor. Now this is a malignant tumor. Okay, so that was to prime you to understand what I am going to show in the specimens which are there in our laboratory. See, now this is a specimen in your museum, and if you look at the specimen, what is that you are finding? Obviously, the shape is telling you that it is a uterus. So, uterus and the cervix. It is the specimen of uterus and the cervix which is showing dilatation of your endometrial cavity, and there is a polypoidal growth into the endometrial cavity. Polypoidal growth into the endometrial cavity and filling the endometrial cavity. So, and here also you find the same thing. Okay, a friable, a necrotic, and a polypoidal growth is called is usually a carcinoma. Yes, this is a closer view. See, this is your cervix, this is your endometrial cavity which has been dilated, and you are having a polypoidal growth which is filling the endometrial cavity. Okay, exophytic polypoidal growth. Yes, and here the differential diagnosis would be an endometrial polyp or an endometrial carcinoma. The endometrial polyps are usually small and they arise at the fundus, and they usually do not grow to this size. This is a polypoidal and a friable mass which is completely filling your endometrial cavity. So this is a specimen which is there in our museum, in our laboratory, where the excised specimen has been cut open and fixed in the formalin and preserved in the museum for your study. Okay, so now when we go into the tumors of the uterine corpus, that is the body of the uterus, we can divide them into epithelial tumors and their precursors. Epithelial tumors means those which are arising from the endometrial epithelial lining. And then we also have mesenchymal tumors. We have mixed epithelial and the mesenchymal tumors, and we have many miscellaneous tumors. We can have lymphoid, myeloid tumors and secondary tumors. these tumors are very rare. The most of the tumors which we find are the epithelial tumors and their precursors. Now, if you look at this specimen, what is that you are finding? You are finding that that it is arising from the endometrium. Yes, is this not the endometrium? This is the myometrium. It doesn't seem to be arising from the myometrium. It is arising from the endometrium. So this comes under the epithelial tumors. Okay. Though we are having so many other things, now this is the epithelial tumor of your uterine corpus. Now let us see what is endometrial carcinoma. Now endometrial carcinoma, it is the most common invasive neoplasm of the female reproductive tract. Yes, mind you, it is the most common invasive neoplasm. In all of the systems, it is the benign tumors which are the most common tumors. It is the same case even with your uterus. Leiomyoma is the most common thing. But when we take invasive neoplasms, what do you mean by invasive neoplasms? That means the malignancies. What malignancies? So endometrial carcinoma is the most common malignant tumor of the female reproductive tract. Okay, we call them as it seems like it is arising from the endometrial epithelium, but when you look at it, it is not a homogeneous type of the tumor. It doesn't, all the tumors, all the endometrial carcinomas do not have the same prognosis, do not respond in the same way to the chemotherapy which is given. That is because these tumors are heterogeneous group of tumors. When you look at the molecular pathology, that is which genes are affecting the causation of this endometrial carcinoma, when we study at that, we find that it is not a homogeneous group, but it is a heterogeneous group of tumors which are derived from the endometrial glandular epithelial cells. If you remember, endometrium is made up of your glandular epithelium, surface epithelium, glandular epithelium, and your endometrial stroma. So this, when we are talking about endometrial carcinoma, we mean that these are the tumors which are arising from the endometrial glandular epithelium. Okay, is it clear? Then, now for the sake of remembrance and for the sake of treatment of these patients and prognostication, the endometrial carcinoma is divided into two types. One is the endometrioid carcinoma. The first one is called as endometrioid carcinoma and their variants, which is type 1. Type 1 carcinomas of the endometrium. They are endometrioid carcinomas. And the second group is the non-endometrioid type 2 carcinomas. Okay. What do you mean by the term endometrioid carcinoma? Here we are saying, you look at the difference of the terms which we are using. When we are talking about endometrial carcinoma, it means that all those gross tumors which are arising from the endometrium, that is called as the endometrial carcinoma. When we look at the histology, that is when we look at the microscopic sections, we divide them into two broad categories. One is the endometrioid carcinoma, the other one is the non-endometrioid carcinoma. Endometrioid carcinoma means a carcinoma which is having resemblance to the endometrial glands. Those are the ones which are termed as endometrioid carcinomas. So, endometrial carcinoma is grossly any tumor arising from your endometrium. That is called as endometrial carcinoma. Grossly. Okay? And when you look at it under the microscope, and when that histological section is resembling your endometrial glands, then you term it as endometrioid carcinoma. And the other one is the non-endometrioid carcinomas of the endometrium. Okay. So, endometrial carcinoma, they are mainly of two types. The endometrioid carcinoma and their variants, which is type 1, and the non-endometrioid carcinoma, which is type 2 carcinomas. So the maintenance of the resemblance to the endometrial glands, which is called as the differentiation of the tumor, that is what is the meaning of the term endometrioid carcinoma. Okay, so now we said that endometrioid carcinoma is and its variants are called as type 1 carcinoma, and non-endometrioid carcinomas are called as type 2 carcinomas. Now let us see the differences between type 1 and the type 2 endometrioid carcinoma. Endometrial carcinoma. Here you will see the term endometrial carcinoma, right? So type 1 is endometrioid carcinoma, type 2 is non-endometrioid carcinoma of endometrial carcinoma. Okay, so we don't get confused with the terms which we are using. Endometrial carcinoma means all carcinomas arising in the endometrium, and when they resemble histologically to the endometrial glands, then we call them as endometrioid carcinoma. Or not all endometrial carcinomas are endometrioid carcinomas. Okay, you are having two varieties. One is endometrioid carcinoma and the other one is endometrial carcinoma. The other one is non-endometrioid endometrial carcinomas. Okay, so the first one is the endometrioid carcinoma is called as type 1 carcinomas, and the non-endometrioid type are usually termed as type 2 carcinomas. Okay, and let us see what are the differences between type 1 and type 2 carcinomas. In the type 1 carcinomas, usually their average age is 50 to 60 years. That is, they are just post-menopause. We can call them as perimenopausal. They are just post-menopausal. Average age is 50 to 60 years. And in type 2 carcinomas, the average age is 60 to 70 years. That is, they are occurring in the women who are a little these are the women who are a little older in age group. Okay, and now in this type 1 carcinomas, usually there is estrogenic stimulation. If you look at your perimenopausal stage, that is the stage where in just before and after menopause is attained, the perimenopausal stage, you are having a lot of estrogenic stimulation of your endometrium. Okay, unopposed estrogenic stimulation. Do you remember the different phases of your endometrium? It is having a estrogenic phase and a progesterogenic phase. Okay, so here in the perimenopausal stage, most of the cycles are anovulatory cycles. Even after the cessation of the menses, there are few cycles where there is estrogen production, but there is no progesterone production. So estrogenic stimulation is present in type 1 carcinomas. That is totally absent in type 2 carcinomas. So these carcinomas, type 1, are hormonally related. They have a relationship with the hormones, and whereas type 2 doesn't have such a relationship. So obviously when you are having an hyperestrogenic state, those cases are having a risk of presentation of hyperplasia. So these are having, the type 1 carcinomas are having the precursor lesions in the form of atypical hyperplasias. This type 2 carcinoma is not associated with atypical hyperplasia of the endometrium. Okay, and when you look at the grade of the tumor, what do you mean by the grade of the tumor? When you look at a tumor under the microscope, if it is resembling the endometrial glands, almost up to 50% or more, we call them as well differentiated. That means the resemblance to a normal cell is still maintained. That is called the degree of differentiation of a tumor to the normal tissue, or is called as the grading of the tumor. Okay, so the degree of the differentiation is high in the cases of your type 1 carcinomas. So usually they are the low grade tumors, whereas type 2 carcinomas are high grade tumors. That means they are poorly differentiated. So whatever cell they are resembling, that is very poorly it is resembling that cell. Okay, so these are usually high grade. Whenever we are talking about tumors, we need to know about two things in the tumor. One is the grade of the tumor, the other one is the stage of the tumor. What do you mean by the grade of the tumor? Grade of the tumor means it is the resemblance of the carcinogenic cell to the normal cell. How much is it resembling? Is it very well resembling that cell? Then we call it as well differentiated carcinomas. When they are not having a differentiation and they are looking very primitive, we call them as non-differentiated or poorly differentiated carcinomas. In between is your moderately differentiated carcinomas, and that is called as the grading of the tumor. Please remember, we are concerned with two things when we are talking about a carcinoma. One is to which tissue is the carcinoma resembling histologically, and how much is it resembling. Well resembling ones are called as well differentiated carcinomas. Differentiation, well differentiated carcinomas, and the poorly differentiated ones do not have a resemblance to the native tissue, and this is called as the grading of the tumor. Okay, and then we are having the staging of the tumor. Staging of the tumor means what is the extent to which the tumor has spread. Is it still there in the endometrium? Has it gone into the myometrium? Has it gone into the cervix? Has it gone into the pelvis? Has it gone into the distant metastasis? That is what is called as staging. Okay. So now, when it comes to the grading of the tumor, usually the type 1 tumors are the low grade tumors and the type 2 tumors are high grade tumors. Means they are less differentiated. Okay. And when you look at these tumors under the microscope, in the type 1 carcinomas, they usually are the endometrioid carcinoma. That means they are resembling the glandular endometrial epithelium, and they can be mucinous carcinomas. Mucinous carcinomas means the carcinomas which are producing lot of mucins. Okay. In type 2 carcinomas, you are having serous and clear cell carcinomas. They do not resemble your endometrial glands. That is the type 2 carcinoma. And usually well differentiated and the low grade tumors are less invasive. So in the type 1 tumors, the myometrial invasion is minimal, whereas in type 2 tumors it is much deeper. Okay, and the tumor spread, usually it is the lymph node involved, and here it is the peritoneal spread more common. That means it is more widespread rather than just to the lymphatics. And when you look at the molecular pathology also, in the molecular pathology, the type 1 tumors, they show a microsatellite instability and P10 and the KRAS mutations, whereas the type 2 carcinomas are P53 mutations. Okay, so this is the pictorial diagram to make the differences between type 1 and type 2 carcinomas. This is type 1 and this is type 2 carcinomas. See, type 1 carcinomas, they are occurring at just a perimenopausal stage. So the uterus will be a little bulky. And whatever the type 2 carcinomas occur in the atrophic uterus. That means the estrogen is not at all there. When you do not have estrogens, what happens? The atrophy of the uterus occurs. Look at the small size of the uterus here. So this is type 1 endometrial carcinoma, this is type 2 endometrial carcinomas. These type 1 endometrial carcinomas are usually related to the estrogenic stimulation, unopposed estrogenic stimulation. Okay, so first they will have the P10 mutations in this, followed by the other microsatellite mutations, microsatellite instability, and then here it is usually only the P53 mutation which occurs. P53 mutation, P53 gene is an anti-apoptotic gene. Okay. Okay. So we had been telling that endometrial carcinoma is not a homogeneous group; it is a heterogeneous group of the tumors derived from the endometrial glandular epithelium. So what is the molecular classification of endometrial carcinoma? One is p53 mutations. This is usually seen in cases of type 2 carcinomas. The other one is microsatellite instability, and we also have a group where you are having polymerase epsilon exonuclease domain mutations, and then there is another group where we do not have a specific mutational profile. Yes, so this is type 1 endometrial carcinoma. What is type 1 endometrial carcinoma? It is endometrioid carcinoma, which is estrogen related, and it comprises almost up to 90% of the cases of the endometrial carcinoma, and usually most of them are low grade endometrial carcinomas. You do have grade 1, grade 2, low grade, moderately differentiated, high grade endometrioid carcinomas, but most of these endometrioid carcinomas are low grade endometrioid carcinomas. Then we have the type 2 carcinomas, which is non-endometrioid carcinoma, and they comprise only about 10% of the endometrioid carcinomas. Okay, and these are serous carcinomas, clear cell carcinomas, and carcinosarcomas. Usually that means, and these do not have a differentiation towards the endometrial glandular epithelium. Okay, this is type 2. And then we do have approximately nearing 5% of the endometrial carcinomas which are not having any of these mutational profiles. So they are of uncertain type of the endometrial carcinomas. Right? So endometrioid carcinoma grade 1 and grade 2, endometrioid grade 3, mixed uncertain type, and non-endometrioid. Non-endometrioid is the type 2 carcinoma. This is type 1 carcinoma. So in type 1 carcinomas, we are having beta mutation, beta catenin mutation, KRAS mutations, and microsatellite instability. Okay, this can occur in endometrioid and in uncertain group. Whereas p53 mutation can occur, it is mainly the pathogenic factor for non-endometrioid, that is the type 2 endometrial carcinoma, and also of mixed uncertain carcinomas. This can also be seen in endometrioid grade 3 tumors, but never in the low grade endometrioid tumors. Okay, so now to tell you, we are having a large list of epithelial tumors and their precursors. The WHO has classified it into so many groups. For you to remember, we divide it as type 1 and type 2, and then they are endometrial carcinomas, endometrioid and non-endometrioid. Okay, now endometrioid, again they are having different variations. Okay, and now non-endometrioid is serous carcinoma, clear cell carcinoma, all these are non-endometrioid carcinoma. If you look at the WHO classification, we have numerous varieties of the histological types of endometrioid carcinoma, endometrial carcinoma, endometrial carcinoma, and the most common of it is the endometrioid carcinoma. Almost 80 to 90% of them are endometrioid carcinomas, and 10% of them are endometrial, non-endometrioid carcinomas. We do have mesenchymal tumors and all the other tumors. That is the WHO list. Okay, so did you understand what I am trying to tell you? The malignancies of the uterus, they are divided into epithelial tumors and the mesenchymal tumors. Mesenchyme means those which are arising from your myometrium and the other mesenchymal elements. It is the non-epithelial tumors. Okay, in the epithelial tumors, you are having precursor tumors and the carcinomas. Okay, precursor, we should call them as precursor neoplasms. Precursor lesions, we should rather call them, and then we are having carcinomas. Okay, now this precursor lesions which turn into carcinomas are usually 90% of the times they are the endometrioid carcinoma, and that endometrioid carcinoma also has different variations. And then the other one is the non-endometrioid carcinomas, which are these three. Okay, type 2. This is type 1 and this is type 2. And then these are all the mesenchymal tumors. Mesenchymal tumors of the uterus are very rare. This is only to show you how vast the list of the tumors is. Now, the second one is that was about differentiation. When we talk about differentiation, we talk about the grading of the tumor. Sorry. When we want to know the extent of the tumor, we look at, most of the times it is the TNM classifications which occur in almost every organ system. Even in the uterus, it is the TNM system which is used, and then in that, what is that? T means tumor, the size of the tumor, and how much of the surrounding tissue has been invaded is what is taken into T. N means how many of the lymph nodes and which lymph nodes are affected. M means distance metastasis, and all the three are taken together, and when it is only the tumor which is present, it is stage 1A, and stage 1. When the tumor is much bigger and it invades the myometrium, we call it a stage 2 tumor. And then when you are having stage 3 is, what is stage 3? Here 3A, yes, here. This is local and regional spread. Okay. So what is the local spread? Tumor invades the serosa. So whatever goes out of the myometrium, it comes into stage 3. Okay. And stage 4 where you are having distant metastasis. So whenever we are talking about carcinoma, we talk about the grade of the tumor. That is, under the microscope, how much differentiation has occurred. That is, how much is it resembling the native tissue there. That is called as the grade of the tumor. How much is the extent of the spread of the tumor to the surrounding tissues is called as the stage of the tumor. So, if you look at our specimen here, what is that here? See, this is a tumor. Okay, this is, first you have to identify the specimen. The specimen is that it is the uterus with cervix. That is, total hysterectomy has been done. Okay, this is a specimen of uterus and cervix, and I have identified that it to be a uterus with the pear shapedness and the cervical canal and the cervix here. Okay, so uterus and the cervix. And what is that you are finding? We are finding a dilated endometrial cavity which is filled up with a polypoidal mass which is friable, and it seems to be arising from the endometrium. So this could be a case of endometrial carcinoma. Okay, this is what it is gross. And once this has happened, what you need to do? You need to do a microscopy of this structure, of this growth, and that microscopy will decide whether it is an endometrioid this is endometrial carcinoma. The microscopy will decide whether it is endometrioid carcinoma or non-endometrioid carcinoma. Endometrioid carcinoma is related with P10 mutations, KRAS mutations, and microsatellite instability. And usually these endometrioid carcinomas are low grade, whereas your non-endometrioid carcinomas, this uterus will be atrophic. If you remember the previous slide which I have shown you to show you the difference between the endometrial carcinoma and the endometrioid carcinoma. Look at this. Yeah, this is usually a uterus will be a little larger, and the type 2 carcinoma, non-endometrioid endometrial carcinomas, the uterus will be atrophic. So obviously from this specimen, what is that we understand? This must be probably a type 1 endometrial carcinoma. How are you going to decide? You will decide it by microscopic examination. Okay, so these are the questions which we usually ask in your viva. So you have to identify the specimen. What is the specimen? It is the uterus and the cervix, and then you are finding a growth in the endometrial cavity the uterus doesn't seem to be atrophic. And then the points which you need to remember here. One is that it is a uterus and cervix, and the uterus seems to be normal. It is not an atrophic uterus. Okay, and then there is an endometrial polypoidal growth which is friable. So this could be an endometrial carcinoma. And because type 2 endometrial carcinomas occur in an atrophic uterus, and this uterus doesn't seem to be atrophic, we can put this carcinoma into type 1 endometrial carcinoma, but it has to be decided by microscopy and your molecular pathology. Is it clear? Yes. So first identify the specimen as uterus and cervix. Right? The shape and this cervical canal will tell you that it is a uterus and cervix. Your uterine cavity is dilated. Why is it dilated? Because there is a mass in that. Okay. What it is? There is a friable mass which is entirely occupying the endometrial cavity, and it is growing out into the cavity. It is not that is called as an exophytic polypoidal growth. Yes. So this is the specimen of uterus and cervix, showing a dilated endometrial cavity which is having a polypoidal exophytic growth filling the cavity, and it is friable. So this is endometrial carcinoma. The uterus seems to be normal and not atrophic. So this could be a type 1 endometrial carcinoma, and when we do a microscopy of this growth, it might resemble the endometrial glands, and so we can call it so it might be a endometrioid endometrial carcinoma. Is it clear? And if you do a molecular pathology, probably this will show P10 mutations, and then it will show KRAS mutations. It might show microsatellite instabilities. Yes. So this is the specimen. Right. Okay. So now I end this class and come back and write your assignment.